You know that feeling, right? When you maybe push it a bit too hard with a new workout and your muscles just ache, like really ache, almost bruised.
Oh, yeah, definitely.
Well, imagine taking that feeling and dialing it way, way up to the point where your actual muscle fibers are, well, breaking down.
That's pretty much what we're talking about today.
Exactly. We're doing a deep dive into rhabdomyolysis.
That's right, rhabdomyolysis, or rhabdo, you sometimes hear people call it. It might sound a bit intimidating, but understanding the basics is actually really important.
So this is kind of our high-yield rundown, getting the key facts straight for revision.
Precisely. We're aiming for a clear, useful overview based on the revision notes, covering all key areas you need to know.
Okay, great. Let's jump right in there. Rhabdomyolysis. What's actually happening? What's the core issue in the body?
So, put simply, it's the breakdown of your skeletal muscle tissue. The muscle cells, the fibers, they basically rupture. And when that happens, all the stuff that's normally kept inside those cells spills out into your bloodstream. Think of it like loads of tiny balloons inside your muscles, just popping all at once.
Right. Okay. And what's the stuff that spills out? What are the key things we worry about?
Well, the main players are myoglobin. That's a protein muscles use to store oxygen, and an enzyme called creatine kinase, or CK. Lots of CK in muscle cells.
Myoglobin and CK. Got it.
Yeah, and other things too, like potassium, phosphate. But the biggest immediate concern really is the myoglobin. It can overwhelm the kidneys and cause damage.
Kidney damage just from muscle breaking down.
Wow.
Okay, that sounds quite serious.
It definitely can be.
So what causes this? What actually triggers this kind of breakdown? Are there common culprits?
Yeah, there's quite a range of causes, but we can group them to make it a bit easier to remember. Actually, there's a helpful acronym, METRIC.
Oh, nice. Metric. Okay, let's hear it.
Sure. So M is for muscle injury. This is, direct trauma like crush injuries or even really severe muscle strain.
Okay, M for muscle injury.
E is for extreme exertion. Think running a marathon when you're not trained for it, or maybe starting a super intense workout routine out of the blue.
Right. Makes sense.
T covers toxins and medications. This is a big category. Alcohol misuse, certain drugs like statins, cocaine, even some toxins like snake venom fit here.
Statins, interesting. We should probably come back to that.
Definitely. Then R is for reduced blood flow to the muscle, like if someone's been immobile for a very long time or maybe during certain types of surgery.
Okay.
I stands for infections. Some viruses like influenza or bacterial infections can sometimes trigger rhabdo.
Wow, even infections.
Yep. And finally, C is for conditions. So underlying issues like certain genetic muscle disorders, metabolic problems, or inflammatory conditions like myositis.
Metric. Muscle injury, extreme exertion, toxins, meds, reduced blood flow, infections, conditions. That's actually really useful for remembering the categories.
I'm glad it helps.
So are some people just more likely to get this? Are there specific risk factors we should know about?
Yeah, absolutely. Certain things definitely increase the risk. Pushing yourself really hard physically, especially in like extreme heat or cold, that's a big one.
Okay.
People taking certain meds, as we mentioned, particularly statins. Illicit drug use is a factor. Having a pre-existing muscle disorder obviously makes you more vulnerable. And dehydration, being really dehydrated, that also significantly increases the risk.
So it's like a mix of putting stress on the muscles and maybe having some underlying vulnerability.
Exactly.
That's a good way to put it.
Okay, so we know what it is, the causes, the risks. Let's get into the mechanism a bit more, the pathophysiology. How does this muscle breakdown actually cause the problems, especially the kidney damage? What's the sort of chain reaction?
Right. So first, those muscle cell membranes get damaged or rupture. That's the initial event. This leads to that release of all the intracellular stuff we talked about, myoglobin, CK, potassium, phosphate, urate. And interestingly, calcium actually rushes into the damaged cells.
Calcium goes in. Yeah, and that increased intracellular calcium isn't good. It can actually trigger programmed cell death, apoptosis, which makes the damage even worse. It sort of perpetuates itself. Then the myoglobin gets into the bloodstream. That's myoglobinemia. And you often see this spike in myoglobin before the CK levels really shoot up.
Right. Timeline matters. And it's this myoglobin that's the main villain for the kidneys. How does it do the damage?
Pretty much, yeah. The kidneys are trying to filter this myoglobin out of the blood. But when there's a lot of it, it can be directly toxic to the kidney tubules, those tiny filtering tubes.
Okay.
Plus, it can kind of clump together or precipitate and form casts that physically block the tubules.
Yeah.
This is worse if the urine is acidic or if the person is dehydrated, which they often are in these situations.
And that blockage and toxicity leads to
Acute kidney injury, or AKI. And one of the really key signs that there's a lot of myoglobin getting into the urine is the color change. It turns dark, like tea or cola.
that dark urine.
Exactly. And another thing, on a standard urine dipstick test, it will usually flag up as positive for blood. But when you look under the microscope, you might not see many actual red blood cells. It's the myoglobin reacting with the test strip.
Ah, so the dipstick sees myoglobin as blood. Good tip.
Yeah, important distinction. So dark urine plus a blood-positive dipstick without many red cells.
Yeah.
You should definitely be thinking about rhabdo.
Okay, that's a massive red flag then. But could other things cause similar symptoms? What else might be on the differential diagnosis list?
Good question. You always have to consider other possibilities. Obviously, simple muscle strain, but also more serious things like compartment syndrome.
Where the pressure builds up in the muscle.
Exactly. Yeah, that's an emergency. You'd also think about other muscle disorders, maybe inflammatory ones, and of course, other causes of acute kidney injury that aren't related to muscle breakdown.
Right, got to rule those out. Okay, let's talk numbers for a second. How common is rhabdomyolysis? Do we know much about the epidemiology?
Well, in the UK, the exact incidence isn't super well established. We know it happens across all ages, all genders, but the rates probably vary depending on things like, how many people are doing extreme sports or patterns of drug use.
And elsewhere, like the U.S.?
In the U.S., they have a bit more data. They estimate around 25,000 cases per year. And of those, somewhere between, say, 5% and maybe up to 30% develop acute kidney injury.
Wow, 25,000. That's quite a few.
It is. It seems to be more common in adults, especially men. And some studies suggest higher rates in African-American individuals, people with obesity, and those over 60.
Interesting demographics. Any differences in causes for different groups?
Yeah, a bit. For example, in kids, infections are actually a more common trigger than, say, extreme exertion. And sadly, during major disasters with lots of crush injuries, you see big spikes in what's called crush syndrome, which is essentially traumatic rhabdomyolysis.
Right, of course. Okay, so let's imagine someone has developed rhabdomyolysis. What would they actually experience? What are the classic signs and symptoms we should look for?
There's often variability, but you look for the classic triad. First, muscle issues. Pain, tenderness, maybe swelling, often in the big muscle groups like thighs, calves, lower back.
Okay, muscle pain?
Second, that characteristic dark urine. Tea-colored, cola-colored. This is really the hallmark sign, if it's present.
Dark urine?
And third, muscle weakness. This can range from mild to quite severe, making it hard to move.
Pain, dark urine, weakness, the triad.
Exactly. Beyond that, people might feel generally unwell fatigue, maybe a fever, nausea, vomiting. Sometimes, particularly in older adults, or if it's very severe, they might get confused or agitated, show signs of delirium. And signs of dehydration are common too, like decreased urine output, maybe even no urine output in anuria.
And what about those electrolyte problems you mentioned earlier? How do they show up?
Right. The release of potassium from the damaged muscle cells is a big one.
Yeah.
High potassium hyperkalaemia is really dangerous because it could affect the heart's rhythm. It could lead to things like heart block, dangerous fast rhythms like ventricular tachycardia, even cardiac arrest, asystole.
Okay, so hyperkalaemia is a major worry.
Huge worry. Conversely, calcium levels can sometimes drop hypocalcaemia. This can cause muscle cramps or twitching, sometimes called tetany, and can also contribute to heart rhythm issues.
So potassium up, calcium potentially down.
Generally, yes. And phosphate levels often go up too. In really severe cases, you can get a condition called DIC, disseminated intravascular coagulation. That's where the blood clotting system goes completely haywire. Very serious.
Wow. Okay, so a lot can go wrong systemically. If you suspect rhabdo based on these signs, what tests are crucial for diagnosis?
The absolute key investigation is a blood test for creatine kinase, CK. In rhabdomyolysis, the CK level will be significantly elevated. We're talking usually at least 5 times the upper limit of normal, often much, much higher. Persistently high CK is the biochemical hallmark.
So CK is the big one.
Definitely. Then urine analysis, as we discussed. Looking for that dark color and checking the dipstick, it'll likely be positive for blood because of the myoglobin, even without many actual red cells.
Right.
We also need to check electrolytes urgently, potassium, calcium, phosphate, and kidney function tests, like creatinine and urea, to see if there's already evidence of AKI.
Makes sense. Any role for imaging?
Sometimes. If there's been trauma, an MRI or a CT might be useful to assess the muscle injury. Ultrasound can sometimes show muscle swelling. Bone scans can occasionally show muscle uptake in severe cases. But usually the diagnosis relies heavily on the clinical picture and those key blood and urine tests.
And what about finding the underlying cause?
Yeah, if it's not obvious, like major trauma or extreme exertion, or if someone has repeated episodes, then further investigations might be needed. This could include things like a muscle biopsy or genetic testing to look for underlying muscle disorders.
Okay. So we've identified it, we've confirmed it with CK and urine tests. How do we manage rhabdomyolysis? What's the treatment strategy?
The core principles are pretty straightforward, really. First, address the underlying cause if you can stop the offending drug, treat the infection, etc. Second, prevent complications, especially that acute kidney injury. And third, support kidney function if it's already taking a hit.
And how do we do that? What are the main treatments?
The absolute cornerstone of treatment is intravenous fluids, lots of them. Aggressive hydration with IV crystalloids, like normal saline, is critical.
Why fluids?
It helps to maintain blood flow to the kidneys, dilute the myoglobin in the bloodstream, and literally flush it out through the urine, reducing its toxic effect and the risk of blockage.
Okay, fluids, fluids, fluids. Got it.
Yes. Alongside that, very close monitoring and correction of electrolyte abnormalities is vital,
Right.
especially managing that high potassium.
Right.
And as we said, if a medication like a statin is the likely culprit, you stop it immediately. For severe cases, particularly with significant AKI, the patient will need hospitalization, often in an intensive care setting, and they might require renal replacement therapy dialysis to support their kidneys.
So dialysis might be needed if the kidneys fail.
Yes, if the AKI is severe or isn't improving with fluids and other measures.
What about immediate sort of emergency management if someone comes in really sick with this?
Yeah, good point. If they have severe AKI, you manage it using the standard ABCDE approach: airway, breathing, circulation, disability, exposure. Key things are managing fluid overload, if it occurs, despite trying to flush the kidneys, treating the hyperkalaemia urgently, correcting severe metabolic acidosis, and managing symptoms of uremia, which is toxin buildup due to kidney failure. Dialysis is often needed in this context.
And the hyperkalaemia treatment.
For severe, life-threatening hyperkalemia, the immediate step is usually intravenous calcium gluconate. This doesn't lower the potassium, but it protects the heart from its effects. Then you use treatments to actually shift potassium out of the blood and into cells, like giving insulin, along with dextrose, and medications to help the body excrete potassium.
Okay, and what about DIC, that clotting problem?
If DIC develops, the main thing is to treat the underlying cause of the rhabdo. Supportive care is key, and sometimes transfusions of platelets or clotting factors might be needed if there's significant bleeding.
Right. You also mentioned some non-prescribing management earlier, besides the IV fluids.
Well, the fluids are the main non-drug intervention. But sometimes diuretics, like furosemide, might be used cautiously once the patient is well hydrated to try and promote urine flow and toxin excretion. However, they shouldn't be used if the patient is still dehydrated.
Okay.
There's also the concept of alkaline diuresis. The idea is to make the urine less acidic by adding sodium bicarbonate to the IV fluids. This is thought to reduce the risk of myoglobin precipitating in the kidney tubules and causing damage.
Making the urine alkaline helps.
That's the theory, yeah. It's thought to make myoglobin more soluble and less toxic. Sometimes another drug, acetazolamide, might be considered to help with urine alkalinization too. But again, the evidence for routine use of bicarbonate is debated, and aggressive fluid therapy remains the most crucial part.
And if none of that works?
If kidney function continues to decline despite these measures, then hemodialysis is the next step.
Let's quickly circle back to statins because so many people take them. How big a concern is statin-induced rhabdo?
It's definitely a known, though relatively rare, side effect. Statins can cause a spectrum of muscle issues, from mild aches called myalgia to inflammation, myositis, and then, at the severe end, rhabdomyolysis.
Okay.
The risk seems to be higher in certain groups: older people, people on high statin doses, and importantly, those taking other medications that interact with statins, like fibrates or certain antibiotics and antifungals. Also, conditions like hypothyroidism can increase the risk.
So what should someone do if they're on a statin and start getting muscle symptoms?
If someone develops new, unexplained muscle pain, tenderness, or weakness, especially if it's accompanied by dark urine or feeling generally unwell, they need to stop the statin and seek medical attention urgently. A CK level needs to be checked promptly.
And if it is rhabdo caused by the statin?
Then the statin is stopped permanently, or at least for a significant period, and the rhabdomyolysis is treated with the standard management we've just discussed: fluids, monitoring, etc.
Okay, good to know. So overall, what's the outlook for someone who gets rhabdomyolysis? What's the prognosis generally like?
It really varies. It depends heavily on what caused it, how severe the initial muscle damage was, how quickly treatment was started, and whether complications like severe AKI developed.
But generally.
The good news is that with prompt diagnosis and aggressive treatment, especially the fluid resuscitation, most people make a full recovery without long-term kidney damage or persistent muscle problems.
That's reassuring.
However, some individuals, especially if the insult was severe or treatment was delayed, might be left with some degree of chronic kidney disease or ongoing muscle weakness or fatigue.
Okay. And just to summarize the worst case scenarios, what are the major potential complications we really need to watch out for?
The big ones we've covered, really. Acute kidney injury is number one. It's the most common serious complication. Then those dangerous electrolyte imbalances,
Yeah.
especially hyperkalaemia causing cardiac arrhythmias, but also hypocalcaemia and hyperphosphatemia.
Right.
Disseminated intravascular coagulation, DIC in severe cases, compartment syndrome, where swelling within a muscle group cuts off its own blood supply, requiring emergency surgery.
Okay.
Metabolic acidosis can develop due to the release of acidic contents from muscles and impaired kidney function. You might see elevated liver enzymes like AST, but often that's coming from the muscle damage itself, not true liver injury. And of course, any complications related to the original cause like sepsis from an infection or burn.
And are there signs that predict a worse outcome?
Yes, generally the development of significant hyperkalaemia, metabolic acidosis, and particularly the need for dialysis due to AKI are all associated with a poorer prognosis.
So AKI is really the complication to prevent, if at all possible.
Absolutely. Preventing or mitigating AKI is the central goal of early management.
Okay, so wrapping this up then. Rhabdomyolysis, it's a serious condition, muscle breakdown releasing harmful stuff, potential for severe kidney damage, electrolyte chaos, other nasty complications.
That's the essence of it, yes.
But the key takeaway seems to be recognize it early. Think muscle pain, weakness, especially that dark urine. Diagnose it quickly with CK levels and treat it aggressively, primarily with lots of IV fluids.
Exactly. Prompt action makes a huge difference to the outcome.
It's definitely a good reminder, isn't it? How things we might see as fairly normal, like intense exercise or common medications like statins, can, in the wrong circumstances, lead to something this significant. Makes you really aware of listening to your body and seeking help if something feels really off.
Absolutely. Awareness is key, both for patients and clinicians. Hopefully this deep dive gives everyone listening a solid, high-yield framework for understanding rhabdomyolysis, especially useful for revision.
Definitely. And speaking of revision, for more fantastic resources tailored specifically for the MSRA, make sure you check out passthemsSRA.com.
And don't forget, freemsra.com for great free content too.
Brilliant. Well, thanks for joining us on this deep dive into rhabdomyolysis.
My pleasure.